I welcome all of you. I'm Professor Herath here. I'm chairing the session on oral presentation of Sri Lanka College of Internal Medicine. We have three eminent, very experienced judges to judge the oral presentation. We have 11 oral presentation lineup for the presentation today. So in fact, because of the COVID thing, we have done a bit of unusual thing. Generally, the oral presentation is done on the day of inaugurations, on the day of sessions, but today we have to do it a little earlier as a precautions. So let me briefly tell you about how we are going to conduct this one. Basically, we have, as I said earlier, we have 11 presentation, and all are pre-recorded. So we will play recorded version of the abstract presentation, which is going to be around 8 minutes. Then, of course, we'll have 2 minutes for the Q&A session. So at the end of the 2 minutes, we will move to the next one. So let me introduce the three judges joining us today. We have for the Shanti Mendis. She doesn't need any introduction. Of course, all of us know who she is. And we have and also we have Professor Tilak Veeraratne, and also we have Dr. Harith Vimalratne. And let me introduce the first speaker. The first presentation is on predictive value of initial liver enzymes level on the extent of liver damage in dengue. And so these authors are Pralapanava U, Kulratna SAM, Karunatilaka EMPW, Alawattagama ATM, and Gunaratna M. The paper will be presented by Karunatilaka EMPW. So now we can play the recorded version of the oral presentation.
Hello everyone. Let me present our study, predictive value of initial liver enzyme levels on the extent of liver damage in dengue. Approximately 3.9 billion people are at risk of dengue infection worldwide. And in dengue infection, dengue virus can cause acute hepatitis, which is denoted by elevated liver enzyme levels. So we did this study to see whether the initial liver aminotransferase levels significantly predict the aminotransferase levels later on the illness of dengue infection. So we did a retrospective study conducted in Teaching Hospital Peradeniya using the data of dengue patients in 2017, and the data were collected systematically on the ALT and AST levels on fever day 3 and day 5 of dengue illness, and the statistical analysis was done using SPSS 26.0 statistical package. So a total of 514 participants were included in our study, consisted of 76.9 males. The mean age of the population was 33.3 years. We did a simple linear regression analysis to see whether the day 3 aminotransferase levels significantly predict the day 5 aminotransferase levels of dengue illness. And for ALT, we calculated a simple linear regression using day 3 ALT level, which is ALT3, and day 5 ALT level, which is ALT5. And we found a significant regression equation with an R-square of 0.341 for ALT. According to that, the day 5 ALT level is equal to 42.522 plus 0.801 into day 3 ALT level. This equation suggests that there's an increasing trend of ALT level from day 3 of the illness towards day 5 of the dengue fever. And For each 1 international units per liter increment of day 3 ALT level, there's an 0.801 international units per liter increment of day 5 ALT levels. The similar analysis was done to predict the day 5 AST level, which is AST5, based on the day 3 AST level, which is AST3. And we found a significant regression equation with an R-square of 0.363. According to that, the day 5 AST level is equal to 58.857 plus 0.922 into day 3 AST level. This equation also suggests that there's an increased trend of AST level from day 3 to day 5 of the illness, and for each 1 international units per liter increment of day 3 AST level, there's an 0.922 international units per liter increment of day 5 AST level. For example, if the day 3 AST level is 20 international units per liter, then you can substitute this 20 value in the equation for AST3. Then AST5 is equal to 58.857 plus 0.922 into 20. Then the day 5 estimated AST level is 77.297. The similar analysis was done considering males and females as separate groups. According to that, the slopes for female group for ALT and AST were 1.025 and 1.200 respectively, and both were significantly higher than the slopes for the male group, which were 0.714 and 0.701. This means that the increment of aminotransferase levels, ALT and AST, with regard to the day 3 aminotransferase level towards the day 5 aminotransferase level is more in females than in males. So in conclusions, we found an increasing trend of liver enzyme levels from day 3 to day 5 of dengue fever, which suggests that a high enzyme level on day 3 has an excellent predictive value of an even higher enzyme level of day 5 of dengue fever. However, it also suggests that normal liver enzyme level on day 3 does not exclude the higher enzyme level later of the illness, so the extent of liver damage. The increment of liver enzyme levels concerning the initial liver enzyme level is more in females than in males. Thank you.
Paper is open for the discussion, and
may I ask a question, Dr. Karunatilaka? Thank you very much for that presentation. You mentioned that the data from 500 odd patients were systematically collected. What exactly did you mean? Did you hear my question? Dr. Herath, I wonder whether you can hear me.
yeah, I can hear you, madam. I don't know whether the presenter has already joined or not. I'm not really sure. I'm trying to confirm whether he's there in the.
That's okay then.
Yeah, we have not seen him in the screen.
It doesn't look like that he has joined. And shall we, as the presenter is not there, shall we move to the next presentation?
Yes.
Should be okay.
Yeah, so we will move to the next presentation. The next presentation is on efficacy and safety of once weekly thyroxine versus daily thyroxine as maintenance therapy of hypothyroidism, randomized controlled clinical trial. Avthasa Wijayakonda CN, Bulugahapitiya U, Kaluarachi V, Previnan S, Da Silva CH, Vellala V, Jayasuriya A, Wijayatunga U, Rahuman MB, Heva SP, Senaratna BCV, and the paper will be presented by Wijayakonda CN. So shall we play the recorded version, please?
Good morning to you all. Our study is efficacy and safety of once weekly thyroxine versus daily thyroxine as maintenance therapy of hypothyroidism, a randomized controlled clinical trial. Inadequate response to thyroxine replacement in patients with hypothyroidism is a problem encountered in clinical practice. Patient non-compliance is a common reason for that. The need for lifelong treatment on daily basis and the stringent conditions the patients need to follow every day with regard to administration of thyroxine contribute to non-compliance. One way of addressing this issue is administering thyroxine once weekly under ideal conditions for optimal absorption. Long half-life of thyroxine makes weekly administration plausible. The objective of our study was to evaluate efficacy and safety of once weekly dosing of thyroxine compared to daily dosing for maintenance therapy of hypothyroidism. This was a parallel group outcome assessment blinded randomized controlled clinical trial conducted at Colombo South Teaching Hospital from 2018 to 2020. Prior ethical approval was obtained and the trial is registered with Sri Lanka Clinical Trials Registry. Patients with primary hypothyroidism who had achieved euthyroidism with a stable dose of daily thyroxine for at least 3 months were recruited after obtaining written informed consent. We had a number of inclusion and exclusion criteria as shown in the table. Patients were allocated to the intervention group and the control group by simple randomization, which was done centrally by an independent investigator via telephone using a computer-generated random allocation sequence. Those in the intervention group received thyroxine once weekly in a dose equal to 7 times their regular maintenance dose. Those in the control group continued to receive thyroxine regular maintenance dose daily. Trial interventions for a period of 12 weeks. This was an open label trial. However, outcome assessments were done by independent assessors blinded to treatment allocation. Efficacy outcomes included proportion of patients maintained in euthyroid state at 12 weeks and mean TSH and free T4 level at 12 weeks. Safety outcomes were assessed at 2 time points. At 4 to 6 hours after first dose of thyroxine to look for acute toxicity and at 12 weeks to look for chronic toxicity. And the safety outcomes included mean end-diastolic diameter and ejection fraction on echocardiogram, proportion of patients with new onset ECG changes, mean blood pressure, mean heart rate, and mean hyperthyroid symptom score, which is a validated tool to screen for hyperthyroidism, mean visual analog Arizona integrative outcome scale score to assess patient well-being. Proportion of patients with biochemically proven hyperthyroidism during or at 12 weeks was another safety outcome. Intention to treat analysis was done using SPSS version 21. Results. After screening 173 patients, we recruited 56 patients. 32 got randomized to once weekly thyroxine group and 24 got randomized to daily thyroxine group. At the baseline, participant characteristics, including the parameters used for outcome assessment, were not significantly different between the two groups. Thyroxine dose during study period. Median dose of thyroxine in the intervention group was 525 micrograms weekly. Median dose of thyroxine in the control group was 75 micrograms daily. Efficacy outcomes. Proportion of patients in euthyroid state, mean TSH and mean free T4 at 12 weeks were not different between the once weekly thyroxine group and daily thyroxine group. When we looked at the thyroid status at 12 weeks, we found that proportion of patients who were euthyroid, hypothyroid, and hyperthyroid were not significantly different between the intervention group and the control group. Safety outcomes at 4 to 6 hours after first dose of thyroxine to look for acute toxicity. We assessed mean end-diastolic diameter, mean ejection fraction, mean systolic and diastolic blood pressures, and mean heart rate to look for cardiac toxicity. Mean hyperthyroid symptom score was assessed to screen for hyperthyroidism. Mean visual analog AIOS was done to look for patient well-being. There was no significant difference in any of these parameters between once weekly thyroxine group and daily thyroxine group. Same safety outcomes were assessed at 12 weeks to look for chronic toxicity. Again, there was no significant difference between the once weekly thyroxine group and the daily thyroxine group. There were no new onset ECG changes, tachyarrhythmias, stable angina, acute coronary syndromes, heart failure, or deaths in any trial participant during the intervention period of 12 weeks. There were no serious adverse events. Coming to the discussion, I would like to say that there is limited evidence from a few previous studies showing that once weekly therapy with thyroxine is as effective as daily therapy in maintenance of euthyroidism. It does not cause hyperthyroidism or cardiac toxicity. However, there is only one previous RCT with a reasonable number of participants, which was 100. This RCT did not look at the cardiac toxicity. The other two RCTs which looked at cardiac toxicity were very much limited by the small sample size. Rest of the evidence come from one phase 1 trial, one observational study, and a few case reports. Our study is also limited by small sample size. We could not reach the required sample size of 98 as COVID interfered with patient recruitment. However, in addition to efficacy, we assessed acute and chronic toxicity with regard to hyperthyroidism, echocardiographic parameters, ECG changes, blood pressure, and heart rate. We also assessed patient well-being. I would like to conclude with these remarks. This small study indicates that weekly dosing of thyroxine is as efficacious and safe as daily thyroxine for maintenance therapy of hypothyroidism. Data obtained from this study add to the existing limited evidence reported from other countries. Further research with a larger sample size is recommended. I would like to acknowledge and thank all trial participants. Thank you.
Thank you, Dr. Vijay. The paper is open for discussion now.
Yes, Nirmala, now you have assessed for about 12 weeks now hypothyroidism is a chronic disease. Now, was there any previous studies, the duration is longer than 12 weeks and because thyroxine, most of the patient will have to give a very long periods, sometimes lifelong. So the long-term efficacy of this strategy has ever been assessed longer than your study?
Only 3 previous studies were there, as I have mentioned in the discussion, and in all 3, the endpoints were assessed at 12 weeks. That was
Right.
Dr. Vijay Kon, thank you for that presentation. I have a clarification. You said
Yes, madam.
electrocardiography was done. I would
Yes.
like to know how often and at what point of time
Yeah,
after administration.
at the same time points as other safety outcomes. So at the baseline, we did it to exclude any existing ischemic heart disease or arrhythmias or anything. Then to look for outcomes, one time point was 4 to 6 hours after the first dose. Like in the intervention group, they must have taken 7 times the usual dose, and the other group, it was the usual dose. After taking the dose in the morning, they came to the hospital, and like within 4 to 6 hours, we did the electrocardiogram and echocardiogram both. That is one time point. The other one was at the end of the trial period, that was at the 12 weeks. So we did it only at 2 points, but like as a safety outcome, we advise the patients to report immediately if they develop any chest pain or shortness of breath or any faintishness, but there was no patient with none of the patients developed any of these symptoms. So there was no need for doing any ECGs at the interim period.
What about palpitations in the group that received once a week thyroxine?
Palpitations were looked at actually in that hyperthyroid symptom score. That is one of the parameters checked in that, but I can't remember exactly how many had palpitations. I looked at the score as a whole, hyperthyroid symptom score, which is marked out of 40. In both groups, the score was less than 5 actually, 4 point something.
Thank you.
Thank you, Dr. Vijay Kon. So with that, we will move to the next one. The next presentation is on standards of care of management of diabetes among rural cohort in Sri Lanka, a descriptive study. The paper, the authors are Chaturanga PADU, Migoda Vidanage N, Ratnayaka TM, Luke WANV, Methananda KCD, and the paper will be presented by Chaturanga PADU. Shall we play the video, please?
Today I am going to present a study done on standards of care of managing diabetes among a rural cohort in Sri Lanka. Type 2 diabetes is the commonest metabolic disorder in the world. In 2017, 8.8% among the population aged 20 to 79 years in the Asian continent had diabetes. And in Sri Lanka, studies have shown the prevalence of diabetes is around 10%. Poor compliance to treatment is a major contributor for rising incidence of diabetes complications. And most studies in this regard is done in the urban population, and there's lack of local studies in the rural population. Therefore, we conducted a study on prescription practices, glycemic control, and correlates in diabetic patients from rural Sri Lanka. So, objectives of this study were to assess the standards of care and disease control among diabetic patients from rural Sri Lanka, to identify common prescription practices, assess compliance to treatment, and to identify areas for improvement in achieving optimum. This study was conducted in 5 hospitals in Anuradhapura district, in the teaching hospital Anuradhapura, and medical clinics and OPDs of 4 other hospitals. We included all consecutive patients with type 2 diabetes on oral anti-diabetic drugs and who were diagnosed with diabetes 2 years prior to enrollment. Pregnant patients, those who had type 1 diabetes, and those who had diabetes for longer or shorter than 2 years, and those who didn't consent for the study were excluded from the study. We collected data by interviewer and self-administered questionnaires, and the data was collected referring to the patient's medical records on current diabetic management and management trends across the past 2 years. So total of 421 participants were included in this study, of which mean age was 55.1 years. 80.8% were females and majority, more than 98%, were Sinhalese in ethnicity. Majority of our participants either didn't have a formal education or had only received primary education. Prevalence of hypertension in our population was 49.4%, numerically 207, 61.7% had dyslipidemia. So the treatment for diabetes among the participants, 102, that is 23.6%, were on single agent. 319, that is more than 3/4 of the population, were either on dual or combination therapy. When we looked into the various anti-diabetic agents used in this population, majority were on metformin. Sulfonylurea-wise, mostly used drug was gliclazide. When it comes to monitoring of glycemic control, the best investigation is HbA1c or glycosylated hemoglobin, but in this population we noted only 10.4% had HbA1cs done. So management of diabetes were mainly based on fasting blood sugar readings, or in some clinics it was mainly the random blood sugar readings taken in clinics. We studied the compliance to treatment by a self-administered questionnaire. So those who scored more than 70% were classified as good compliance. Among the study population, more than 60% had poor compliance to treatment. 190, that is 45.1%, had fasting blood sugar levels more than 130 milligrams per deciliter, indicating that nearly half of the study population had poor glycemic control even while on treatment. When it comes to other risk factor control, we noted that the study population, majority had the BMIs either in the overweight or obese area. And the mean BMI of the study population was high at 26.5. And more than 50% of the study population were physically inactive. So in this population, we noted 270, that is 64.1%, were on statins. According to recommendations, patients with diabetes over 40 years of age should be treated with moderate intensity statins for optimum cardiovascular risk reduction. Out of our population above 40, when we specifically analyzed, we noted that only 66.1% were on statins, suggesting their scope for further improvement. And 68, that is 16.1%, had LDL levels more than 100. Optimum blood pressure control is important among diabetic patients for cardiovascular risk reduction. In our population, 40.5%, that is a significant population, had suboptimum blood pressure control. A favorable trend we noted was that majority, close to 90% of the population, being on ACE inhibitors or ARBs. Only 4% of the study subjects were smokers, which is a favorable trend. However, the use of smokeless tobacco is known to be high in rural areas, which we didn't really quantify in our study. So concluding my presentation, in our study, We noted even though the majority of diabetic patients were on anti-diabetic medications, their glycemic control was suboptimal. And poor diet and medication control were identified as major contributors to this. Reduced physical activity and high BMI was noted despite being on agricultural-based community. That brings me to the end of my presentation, and thank you so much.
Thank you, Dr. Chaturanga. So the paper is open for discussion.
Thank you, Dr. Chaturanga, for that interesting presentation. You mentioned that only 10% of patients had HbA1c done.
Yes.
Is that because the hospital not offer that as a test? Did they have to do it in the private sector? It would have been expensive. Is that the reason?
Yeah, that's the reason, because majority of these hospitals were rural hospitals which did not have facilities to do HbA1c in the hospital lab. So the patients had to do it outside. So because of that, majority of patients didn't have HbA1c staff.
Do you know the cost of HbA1c test in Sri Lanka?
According to what I know, like it's more than 1,000 rupees. Exact cost, I'm not really sure.
It's about 1,800 rupees. HbA1c.
Yeah, quite expensive. Huh? Thank you.
Thank you, Dr. Chaturanga, for the presentation. Let's move to the next presentation. The next presentation is post-acute COVID-19 symptoms in patients who have been discharged from a tertiary care hospital. Authors are Indrakumar J, Matthias H, Vanigasuriya R, De Silva R, and the paper will be presented by Vanigasuriya R.
Good evening, everyone. First, I'd like to thank the organizing committee for giving us the opportunity to present our research on post-acute COVID-19 symptoms in patients who have been discharged from a tertiary care hospital. For millions of people around the world, COVID-19 infection has unfortunately become not just a discrete episode, but the start of a wide range of debilitating symptoms. According to the CDC, post-COVID conditions consist of a wide range of new, returning, or ongoing health problems that are experienced 4 or more weeks after first being infected with the virus that causes COVID-19. These are also known as long COVID, long-haul COVID, or post-acute COVID-19. Patients are in a state of uncertainty and anxiety as there is no established mechanism available to identify and guide such patients for follow-up. In fact, in a study done in UK by the UK Office for National Statistics, it was estimated that 1 in 5 respondents with COVID infection showed symptoms for 5 weeks or longer. However, in Sri Lanka, there is very little research into the post-discharge health status of COVID-19 survivors. The primary objective of our study was to describe the characteristics of persistent symptoms of patients who have been discharged from a tertiary care hospital after recovery from COVID-19 in Sri Lanka. For this, we chose patients discharged from COVID isolation wards and general medical wards of Colombo South Teaching Hospital and carried out a descriptive cohort study for over 2 months from June 1st to August 9th, 2021. We included all patients with laboratory confirmed COVID-19 who were discharged from Colombo South Teaching Hospital and excluded those who died before the phone survey, those who were unable to be contacted, those who declined to participate, and those who were diagnosed with psychiatric illnesses. Telephone contact numbers were obtained at the time of discharge, and we call them after 4 weeks and ask them to retrospectively recount the presence or absence of symptoms during the acute phase and whether each symptom persisted at the time of the survey. Data was then entered on a Google form and analyzed using SPSS 19 version. Moving on to the data analysis, when analyzing socio-demographic characteristics, 75 out of 150 were males and the remaining 75 respondents were females. The sample had a mean age of 48 years with a standard deviation of 16.989. To summarize the level of care required during the acute illness in terms of their oxygen requirement, a majority of 112 patients required supplemental oxygen. Another 31 did require supplemental oxygen. 6 patients required ICU care, and there was only 1 respondent who was intubated during the acute phase. This table summarizes the symptom analysis of this cohort after 4 weeks of acute infection and has been categorized into respiratory, cardiac, neuromuscular, psychiatric, and other symptoms. In brief, of the symptoms reported by the patients, the most frequently reported symptom was fatigue, followed by musculoskeletal pain or discomfort and headache, represented by 64%, 37.3% and 36.7% respectively. The most common respiratory symptom was dyspnea, and the most commonly reported psychological symptom was anxiety. Many patients have been able to get back to their activities of daily living and also have returned to work, studies, and household chores following acute COVID-19 illness. Further, the patients were asked to rate their overall health status after COVID-19 on a scale of 0 to 10, 10 being the best health one can imagine and 0 being the worst health. 12% gave a score between 0 to 5, while 88% gave a score between 6 to 10. Thus, in contrast to expectations, our study didn't reveal any significant drop in quality of life as reflected by minimal work and social life disruption and the satisfactory perception of their overall health status. The difference in patient characteristics with a much younger crowd as our study population may be a possible explanation for this. So, as a conclusion, majority of our respondents had mild infection in terms of their oxygen requirement, but still there was a significant prevalence of physical and mental health symptoms 1 month after infection, with only a minority being severely affected by post-COVID symptoms in terms of their overall health and the ability to return to previous routines. Thus, with the largest third wave that spread across Sri Lanka recently with rapidly spreading Delta variant, the long-term implications of the illness are of increasing concern. Post-COVID clinics need to be set up to guide these patients who need proper evaluation of post-COVID symptoms to plan necessary treatment. Thank you.
Paper is open for the discussion now.
Was any patient during the 4 weeks of follow-up has readmissions? Because in the other overseas countries, the readmission rate of COVID patients has been quite high. And during your telephone interview, have you included that as one of the post-COVID criterion to be looked at?
Yes, we included patients who were had to be hospitalized again, or those who seek the medical care at a private practitioner as well. And
so what's the percentage of hospital readmission due to likely COVID-related symptom? Like
it was for hospital readmissions were about 15%, and 24.6% had seek medical attention at a private practitioner or a general physician without any hospitalizations.
Right.
For various ailments.
Dr. Manikasuriya, Why did you say that you think it's a good idea to have post-COVID-19 clinics? Because 88%, I thought, had a good score and returned to work. Is there any reason? Would that not prolong the anxiety related to the illness and the patients feeling that they have a severe illness when in fact it may all be due to anxiety?
Even though we found out that the frequency of long-term symptoms in the Sri Lankan population was much higher, even among those who suffered from mild illnesses. And because of that reason, we believe that post-COVID clinics must be set up for follow-up.
Thank you.
Thank you, Dr. Vanika Surya. Let's move to the next presentation. The next presentation is on audit on hand hygiene practice in a tertiary care medical unit in a central province. Paper, the authors are Jaisingh IK, Perera UAW, Dayaratna UHJP, Premaratna BG, Amarasinghe WG MD, Hettiarachchi NM, Manilgama SR, Kulratna WLR, Rotuagama RSHT, Abhay Vikram UK, and the paper will be presented by Jaisingh IK.
An audit on hand hygiene practices in a tertiary care medical unit in the central province. Each year, hundreds of millions of patients around the world are affected by healthcare associated infections. Hands are the main pathway of transmission of infections during healthcare. Hand hygiene is therefore the most important measure to prevent healthcare associated infections according to the WHO. WHO has started the Save Lives, Clean Your Hands campaign in 2009. Ministry of Health in Sri Lanka has issued a circular in 2015 instructing all the units to conduct and present hand hygiene audits quarterly. This is the ministry circular regarding this. There's another reason for this hand hygiene audit. That was during the fourth wave of COVID pandemic, a majority of COVID-19 patients with pneumonia were treated in the medical wards with non-COVID patients. Some non-COVID patients during their hospital stay and few healthcare workers also have contracted the COVID-19. Among other preventive measures, hand hygiene is equally important to curtail the COVID-19 spread. Therefore, we thought of doing this hand hygiene audit. Our objectives were to assess and improve adherence to hand hygiene recommendations at the Medical Unit 1 at the National Hospital Kandy, and to protect patients and the healthcare workers from COVID-19 and other infections. Audit standards were the WHO standards. Any healthcare worker involved in direct or indirect patient care needs to clean their hands correctly and at the right time with 5 moments. They should clean their hands by rubbing them with an alcohol-based formulation at least for 20 seconds or wash hands with soap and water at least for 20 seconds. These are the 5 moments of hand hygiene. Moment 1 is before touching the patient, you should clean your hands. Moment 2, before an aseptic procedure. Moment 3 is after body fluid exposure, such as after touching urine. 4 is after touching a patient. 5 is after touching patient surroundings. Methodology. 4 doctors were educated on WHO hand hygiene audit standards and the hand hygiene audit tool. Auditors were asked to observe up to 4 members of the staff randomly for a period of 20-minute sessions and assess their hand hygiene practices. This is WHO hand hygiene audit tool. You can see up to 4 categories of healthcare workers we can assess. This is a close-up of the one opportunity. The indication is there on the left-hand side. with the 5 moment and hand hygiene action on the right-hand side. If they have done the hand hygiene, whether it's with the hand rub or hand wash, or if they have missed it. Methodology. Data were collected and entered into an Excel sheet and analyzed to get the hand hygiene compliance rates, total compliance for the unit, compliant in each of the 5 moments, and compliance in each of the healthcare worker category. This is how we calculate the compliance rates. For example, if it's for a total hand hygiene compliance, we have taken total correct hand hygiene moments from all the total observed hand hygiene moments. Similarly, we did it for each of the 5 moments and each of the healthcare worker category. Results. There were 60 20-minute sessions and 1,134 hand hygiene moments. However, there were only 553 correct hand hygiene moments. Because of that, the total hand hygiene compliance rate for the Medical Unit 1 at the National Hospital Kandy was 48.8%. These are the compliance rates for each of the 5 moments. Before touching a patient, it was 50.1%. Before aseptic procedure, that was 67%. After body fluid exposure, that was 71.4%. After patient, that was 69%. After patient surrounding was the lowest, that is 26.7%. We have compared with some other units. This is our figures, and this one Nigerian study that showed very low overall compliance, 23.5%. Before aseptic procedure for them, it was 15.7%. That was very low. National Hospital Kandy 5 ICUs in 2015. The overall compliance was 65.5%. One of the neonatal intensive care units in the United Kingdom, which was done in 2020, showed the figures of 80.4%. The compliance rate of each of the healthcare workers. Doctors were the best, 54.39%. Nurses, 49%. Healthcare assistant, 42%. Allied healthcare workers was the lowest, 4.76%. Medical student is still low, 37.14%. Nursing students, 11.76%. We did more hand rub than the hand wash. Whereas in the Nigerian study, it was more hand wash than the hand rub. Discussion and the conclusion. Hand hygiene compliance was not satisfactory among all categories of healthcare workers at the observed medical unit in National Hospital Kandy, and may have contributed to recent COVID infections among healthcare workers and the patients. Low compliance in before and after touching patient may lead to cross-infections. 2 categories of healthcare workers showed very low compliance rates and need more attention. Our recommendations are, we should improve hand hygiene compliance by educating the all categories of staff on hand hygiene practices. Role modeling by absolute compliance by the senior staff. Make alcohol gel available to each of the cubicle and also to the trolleys. To practice hand hygiene even while using gloves to protect patients. Display visuals on hand hygiene practices and the moments. After reinforcement of hand hygiene, a re-audit is recommended to assess the improvement. Seconds will save lives. Clean your hands. Thank you.
Thank you, Dr. Jayasingh, for the presentation.
Thank you, Dr. Jayasingh. That's an important study. You have made some recommendations. Did you convey these recommendations to any decision maker?
Yes, hospital administrators, I have already shown the figures. and I have already discussed with Madam. In fact, the availability of alcohol drop is not consistent always. Sometimes we don't get alcohol drop in some weeks, and some weeks we do get. So they reassure that there will be continuous supply of alcohol drop.
So you had a positive response from the decision-making level of people?
Yes, Madam, at the moment, yes. But I need to see how the things are going on in the future.
Yes, and persevere with the pressure.
Yes.
Thank you.